My name is Bruno Musch. I'm a neurologist. I'm here in Valencia for the 5th World Congress on Sleep Medicine. And I have the pleasure to introduce you Dr. Claudia Trenk-Walter, a neurologist from the University of Göttingen. And Dr. Trenk-Walter is the president of the World Association of Sleep Medicine. I will ask Dr. Trenk-Walter a couple of questions because yesterday we had a very animated, I would say, discussion around drug therapy, but particularly about the importance or the usefulness of drug holidays in patients who cannot tolerate the treatment or have signs of augmentation. So I would like to start with a little bit of a provocative question. We have heard that certain patients, in fact, tend to do well with drug holidays. What is your experience or your opinion from this point of view?
Usually the more severely affected patients are not doing so well with drug holidays, in my experience. This may be true with drug holidays for the milder and younger patients that have a variability of their symptoms, but if there are a lot of comorbidities and other diseases and they have a treatment for several years, if you stop that RLS treatment, this will sometimes cause crisis of hypertension of the cardiovascular system. So we are very cautious, even with tapering off the medication, only slowly, but we are not just stopping any RLS medication because patients may really suffer from that.
Thank you, and I think that the reason why we're talking about drug holidays is because one of the critical topic and challenge in treating patients with RLS is the fact that under treatment they can have what is called a worsening or exacerbation of their symptoms, drug-related, and this is called augmentation. And you yesterday, rightly so, managed that in fact the real topic of interest for the doctors is in fact how we manage augmentation. Would you like to comment on that?
Yes, I think you are right. This is one of the major problems in treating RLS patients, especially with dopaminergic agents. If they get augmentation, how to manage augmentation. I think first thing is that we really should stay with the low dosages that are licensed for dopamine agonists and not go higher. But in fact, we see many patients on high dosages of dopamine agonists or levodopa, and they have severe augmentation. They are pacing around all day, have RLS during the day, have the arms involved, and almost no sleep. So we would then slowly taper off the dopamine agonist, but completely stop levodopa immediately. And for those who cannot tolerate the tapering off, we use intermittently opioids or sometimes pregabalin, or we switch them to opioids at all or to pregabalin if they have side effects, sometimes on dopamine agonists. So if they already have severe augmentation, I would say one should go on an opioid or maybe a benzodiazepine in between, just to relieve the patient's RLS problems for some days or weeks, and then you can reintroduce maybe another low-dose dopaminergic drugs. But for some of them with augmentation on several dopaminergic drugs, I would not reintroduce a dopaminergic agent.
And last question is, at the end of your talk, you mentioned the fact that maybe we should know more about management augmentation through clinical trials. What is your opinion in this respect moving forward?
Yeah, I think that would be very important to know, and there is one ongoing trial that's just an observational trial of how augmented patients have been switched to other drugs and how they are doing on this. I think we will have some results at the end of the year from that trial, but I think we would need prospective trials and see how fast are patients getting augmented and what would be the best management. Should we slowly taper off? Should we always add another drug like an opioid? Should we switch completely from a dopaminergic to pregabalin or gabapentin? So I think these are many open questions, and not the least, we should know that the iron metabolism is very important for those patients, and as others also mentioned, one should measure ferritin in the augmented patient, and if they have a low ferritin, at least below 50, but maybe also below 100, one should first add iron before changing completely the medication, because this may relieve many of the symptoms.
Thank you very much. Well, you will hear more in this program about drug therapy of RLS. I'm sure there will be a continuous debate about how better manage patients, particularly when the drug treatment is not as optimal as it should be. So thank you very much, and congratulations for this very, very successful Congress. Thank you.
Thank you.